Welcome to the APAPP broadcast. We're coming to you from our second annual APAPP National Symposium here in Nashville, Tennessee. And my name is Jessica Glennie. I'm a nurse practitioner at the Cleveland Clinic in Cleveland, Ohio. I practice in the area of interstitial lung disease. And today I'm here with my colleague, Lori Reed. Hi, Lori.
Hi. Yes, I'm Lori Reed. I am a nurse practitioner in Atlanta at Piedmont Healthcare. I take care of all advanced lung disease, interstitial lung disease, pulmonary hypertension, sarcoid there. I really enjoyed presenting with you earlier today, and I'm glad to be here doing this podcast with you.
Awesome. Yeah, so today, we're going to talk a little bit about advancing care in ILD, the diagnostics, management, emerging therapies, and some of the comorbidities that we see with these diseases. So to start off, we're going to chat a little bit about what we kind of hoped our attendees would take away from, this topic. Does anything come to mind for you? Big key takeaways from our topic on ILD?
I think, of course, we did have some good big takeaways. Understanding the background of ILD and PH individually, but also where we're going with those treatment strategies and what's emerging and coming up, and how we manage both ILD and PH-ILD.
Yeah, I think we unpacked a lot during that. There's a lot of information to go over. So, we talked about, first off, kind of the pathophysiology and the burden to our patients. From my standpoint is seeing, really all these ILD patients, it's sometimes very daunting to get an ILD patient and try and work that patient up from the ground up. You have to really delve a lot into a lot of history pieces, really looking at all those diagnostic pieces. When it comes to kind of the burden to the patients, what do you see from your patients? How do they take these diagnoses, and what kind of symptoms are they having when they come to you?
Right. Yeah. So these patients have had symptoms for a long time before they get to us. They've seen their primary care and urgent care, been diagnosed with pneumonia and all these things. And then they've rationalized their shortness of breath and their fatigue and their inability to do the things they used to do, to being older, overweight, all those things. And so then they come and they see us and they get the diagnosis of ILD. And then we create the plan and we get them started on treatment strategies, everything that we know that we can do to help improve their quality of life and lessen their burden of the shortness of breath and the fatigue. And then when they get to me also with the PH-ILD piece, that just compounds on top of the ILD alone. And the symptoms for that are still the shortness of breath, the fatigue, the chest tightness, sometimes dizziness, and right heart failure symptoms of swelling and fluid retention. And so the workup for that's intense too.
Yeah. I mean, these patients are dealing with sometimes not just one disease, but two really bad diseases that together lead to really much more poor outcomes. So, when we're seeing these patients, we're trying to manage not only, the treatment of these diseases, but also non-pharmacologic things, making sure that we're doing some things to help their quality of life, pulmonary rehab. We kind of talked about, oxygen. We talked about advanced care planning and things like that. Those are all really important. And then making sure they have the support and mental support too. Yeah, they're difficult diseases for sure. We talked a little bit about treatments, both from the ILD standpoint of things and PH. I'll say for the interstitial lung disease side, we really have to think about, we talked a lot about the diagnosis. We have to think about that diagnosis a lot when we're trying to determine what type of treatment we're going to put patients on, and also looking at that patient's scan and things like that. You can have inflammation, you can have fibrosis, or you can have both. And so sometimes we have to put these patients on immunosuppression and antifibrotic medication. And then you talked a little bit as well about, the pH side of things. What types of medications do we have for PH-ILD?
Right. So there is medication, treprostinil, inhaled treprostinil, has been FDA approved for the treatment of patients with pulmonary hypertension and interstitial lung disease. We talked a little bit about there being 3 different modalities of the inhaled treprostinil in this phenotype of patients. There are a Tyvaso nebulizer 4 times a day. There's Tyvaso DPI, dry powder inhaler, 4 times a day. And then there's Yutrepia, dry powder inhaler, 4 times a day. All FDA approved, on market. And in those studies that had them approved, showed that patients had less short of breath, improved quality of life, their 6-minute walk distance improved, and their NT-proBNPs had been improved too. And so that's something that we can offer that's directed at the disease. And then again, you and I talked about the oxygen, and pulmonary rehab is really important, and making sure we're treating them as a whole. So those are approved, but then we also know that there's things that are up and coming.
Yeah,
we talked about.
Yeah. I mean, we've got some things down the pipeline in ILD. So one that we talked about was the Teton study, which that's still, the data on that is still not out, but that's utilizing treprostinil in patients with interstitial lung disease, but without PH, and seeing if maybe there is some antifibrotic property to the treprostinil, because they found that in the INCREASE study that people's FVC sometimes stabilized or didn't decline as much, in particular the IPF patients. And so now they're looking at this as, could this be, have some antifibrotic properties, which that would be really exciting if we could put those patients, on treprostinil for their pulmonary fibrosis, because we then also kind of be pre-treating them a bit for, maybe their pH. Maybe we would see less pH in these patients.
It would be interesting
to see. That would be interesting to see. Yeah, for sure. And then we also talked about, now this is data that has come out now, but FDA has not approved yet, for a new antifibrotic called neuredomast. Now, neuredomast has both some immunomodulatory plus antifibrotic components, but really, what they found in studies was patients either, on placebo or on the neuredomast at 2 different doses decreased the progression of their FVC over 52 weeks.
That was in addition on background therapy, whether they were on OFEV or Esbriet.
Both people naive or on medication. So now we have something that we could offer patients in addition to their current antifibrotics to additionally get some more improvement with slowing the rate of fibrosis in those patients. So that's really exciting. And then, Lori, I think you talked a little bit more about some of the upcoming things with PH. Can you go through some of those? You talked a little bit about another trial coming out for a medication.
So there are ongoing trials currently for PH and PH-ILD, and registries currently that are enrolling, so that we can continue to tease out which patients and which phenotypes of these patients respond better to pulmonary vasodilator therapies. And one of the registries, called FINDER, is looking at patients with interstitial lung disease at risk for pulmonary hypertension, and getting them in and helping us decide kind of the protocol for how to screen these patients for pulmonary hypertension to try to catch it earlier, and maybe do something about it.
Yeah. I mean, how important is this to catch these things early? I think we talked about this quite a lot, how there's a diagnostic delay in a lot of finding these in these patients. And this is for a number of reasons. I think our recognition of these diseases is getting much better over the course of the past 10, 20 years or so. But, we still have a long way to go with that. But also, these diseases can have some similar common symptoms to other, maybe more common and with not quite as poor survival, types of diseases like asthma or COPD can cause shortness of breath and can cause cough and things like that. So, I think it's really important that we're making sure that at least there's more awareness about these diseases, because if things aren't fitting, you're putting your patient on an inhaler, you've done a cardiac workup, and these patients are still declining, maybe start looking for something else. I wonder, we talked a little bit about this, but are there some big signs or symptoms that you see that you could say, hey, if you, to all your pulmonary APPs out there, this might make you think of ILD or this might make you think of PH. And I think you mentioned some of them, but just to remind everybody.
Right. So with our ILD patients, we get their pulmonary function testing, follow their FVC, their DLCO. We get their walk test, looking at their distance and their oxygen need. And so when you're following these patients and they're coming in and they're either telling you they're great, no change, and all their testing is staying stable, well, then that's wonderful. That's what we want when we finally do see these patients. But if they're coming in and they're telling you, I'm just a little bit more short of breath, and you get their pulmonary function test and their FVC is staying stable, but they're still feeling worse, well, that's one red flag. The other would be if their FVC is staying stable and their DLCO is dropping and they're disproportionate. There's something else going on. Or on that walk test, if they're not walking as far as they did before, or if they're getting more hypoxic during the walk, or if they're walking and their heart rate doesn't recover as quickly as it had before, those are all subtle signs. And we know that ILD has bad outcomes and pulmonary hypertension has bad outcomes. But ILD with PH just portends worse outcomes, worse mortality. And so if we can get them identified quicker and then get them on treatment strategies and not just pharmacologic, but non-pharmacologic to improve their quality of life and maybe make some gains in their quantity, then that's our goal.
Yeah,
right?
Absolutely. You mentioned the PFTs and, for sure, I'll just mention to everybody out there, that restriction on there. That's when we're starting to think about ILD as one of the possible diagnoses here when we're seeing a lot of restriction. And you mentioned, that DLCO, that'll be low in ILD, but if there's, it's pretty disproportionate, then you start thinking about PH or thinking about other causes, emphysema or other anemia, things like that could be playing into it. I think I didn't mention this during our during the talk, and I just feel so bad that I didn't mention this, but I want to say to everybody, and those general pulmonary people out there, please listen for crackles. Crackles are so important.
Yes.
So if you're listening to your patient and you've been treating them for asthma and you're hearing crackles, they're not getting better, they've got a restriction on their FVC, you want to start thinking about ILD. So definitely something to look for.
Yes. And I do want to follow up with too that, once you see these things on your, hear them from your patients or see them on your PFTs, you need to act on it. You need to do the next thing. And that next thing is to get the echocardiogram, the ultrasound of the heart. That way you can see what that right ventricle looks like. You can see what that right ventricular systolic pressure, that RVSP is. And one thing I did mention that some people would write off is what that RVSP is. So if that right ventricular systolic pressure is 30, 35, that's abnormal, that's high, and that still means you need to look further. And looking further would be referring to a center getting that right heart cath, which the right heart cath is the diagnostic definitive gold standard tool to diagnose the PH-ILD. But I think some people may pause at an RVSP of 30, 35, 40, because if you treat pulmonary arterial hypertension, you're used to seeing that number at 80. But 30, 35, 40, that means something to these patients with ILD.
Does. Yeah, yeah. And to echo that, a bad pulmonary jokes or a PH jokes, going that extra step is well in the form of ILD. You can tell, my ILD focus, your PH focus here, that high resolution CT. We talked about that a bit for our ILD patients, that really is one of the most important things for diagnosis. We certainly can use it to follow along our patients, but definitely the diagnosis of ILD, we need that HRCT to see the pattern of injury. So that's probably one of the biggest tools we use in the ILD. So from kind of the perspective of multidisciplinary collaboration and things like that, there's collaboration both between ILD and PH teams, of course. We also have to have really close collaboration with a radiologist, maybe our cardiologist, things like that. Rheumatologists, all of this. Are you frequently, going over cases or talking to others about, things that you're seeing?
I am. We do in our center have an MDD, a multidisciplinary discussion, where we bring our most puzzling cases. So we do that. But one thing I think is easy for all of us to do that I do because we share a lot of patients that travel a long distance to see us. So they still have relationships with their at-home providers is sending my note back to them, making sure that the patient's other providers are updated on what we're seeing, what we're doing. And my hope is that that's good patient care, good communication for that patient, but also it helps to raise awareness and helps to keep these things top of mind for the providers they're seeing. So maybe the next patient that walks into their clinic, they think a little bit earlier about these things and it just stays a little bit more top of mind.
Yeah. I think each facility might be a little bit different in how they do things. And I'm just thinking about my facility. I wonder, Lori, how it is with you. So we've got our ILD team, we've got our MDD. It's great to come together. Usually our PH team isn't involved in that piece, but we're kind of split. We have an ILD team, we have a PH team. They're a little bit separate, but we a little bit crossover, that type of thing. But we find it so important to have good relationships with each other and chat with each other. Do your providers, are they kind of do it all, or you kind of keep those separate in your facility?
So I am Piedmont's advanced lung disease nurse.
Wonderful.
So maybe I just kind of help. I'm the the middle of that Venn diagram, maybe.
Right.
But no, my physician colleagues do communicate with each other. They'll call each other, text, use our Epic system to communicate, just because our time is so stretched sometimes. I really think that's the way we communicate that way.
And then, I'm thinking about what kind of some of the unmet needs are in the ILD space. And, thinking about that, I really am hopeful, from an ILD's perspective, that one day we'll have some treatments that halt or reverse progression of pulmonary fibrosis. That would be wonderful. But I also am hopeful maybe we could find some things that really help patients with quality of life. We talked about pulmonary rehab, but to really help patients have more energy, less cough, be able to walk further. Treprostinil does that a little bit, so that's great. But maybe some more things in that space to make patients, I'd like to be able to tell a patient I'm going to be able to make you feel a little bit better, so that's great. Any thoughts from you on big unmet needs in either the PH or the ILD space or PH-ILD?
Yeah, I think we've just covered it, making it more top of mind so that everybody thinks about it a little bit sooner so that we can identify these patients sooner. And then continuing studies and registries so that we can eventually figure out what these different variables are, what the phenotypes are, so that we can offer more individualized, specialized care for them.
Yeah,
So.
yeah.
Well, I think that kind of brings us to the end of the episode of the APAPP podcast. A huge thank you to you, Jessica, for sharing today's lecture with me and this podcast with me.
Thank you, Lori. It's been wonderful.
Well, I appreciate it. I appreciate you working with me. We also really want to thank United Therapeutics and Boehringer Ingelheim for their continued support of APAPP, of the conference here, of this session. We appreciate them. And so if you found this episode helpful, be sure to subscribe, share it with your colleagues, explore more content. There's a lot out there. APAPP is doing a wonderful job spreading education. And it's been an incredible opportunity to be here, connect with the conference, with all the colleagues here. And really, I'm looking forward to next year's third annual
Me too.
APAPP.
Everybody come out to APAPP, our third annual next year. Come and meet all your pulmonary colleagues. It's going to be great.
It will be great.